Hello, everyone, and welcome to Arthritis Talks. I'm Dr. Sean Bevan, Chief Science Officer at the Arthritis Society, and thank you for joining us tonight. Time and time again, previous Arthritis Talks attendees have asked that we host an Arthritis Talks focused on arthritis in the hands and feet. Because we use these parts of our body so often, when they are affected by arthritis, almost every move can be accompanied by pain and stiffness. Today, we are very fortunate to be joined by two experts in this area, hand surgeon and clinical investigator, Dr. Heather Baltzer, and advanced practice physiotherapist, Tamara Gotal. Before we get started, a few logistics. This webinar is best viewed on a laptop or desktop computer. If you have technical difficulties, please email arthritistalks@arthritis.ca for assistance. If you have a question for our presenters, you can submit it through the Q&A at the bottom of the middle of the screen. We will try to get to as many questions as possible during the hour that we have together. You can click on the chat icon in the bottom middle of the screen to access the chat and connect with other participants and the Arthritis Society's chat moderator. If you'd like to close out of the chat completely, just click that red X icon to close out of the window. We're pleased to continue to provide captioning of our webinars to accommodate the diverse needs of our audience, and you'll see that running along the bottom of the page. Many questions we received did follow similar themes, so we will address those first before going into the live Q&A at the end of the session. Before we get started, as always, I want to thank our event partners, Pfizer, United Way Winnipeg, and others for their financial support of our Arthritis Talk series. So let's get started. First, a warm welcome to Dr. Baltzer and Tamara. Dr. Baltzer, let's start with you. With respect to the hands, can you just briefly provide an overview of what causes arthritis in the hands? And maybe when you're finished, Tamara, I'll turn it over to you to talk a little bit about the feet.
Sure. Thanks so much, Sean, and thanks very much for the opportunity to participate tonight. It's a real honor to be here. So things that can cause arthritis in the hands include trauma. So if you've had an injury that involves a joint, then that can lead to a post-traumatic arthritis involving any of the joints of the hand. And then other things we consider more risk factors. So you can have a family history of having arthritis, so your genes can play a big role. And those are things that are being currently researched. If you're someone who's done a lot of heavy work with your hands over the years, then that can also contribute to your risk for developing arthritis. And then arthritis specifically at the base of the thumb is more common among women, and particularly women who are postmenopausal. So those are some things that either can cause it, specifically trauma, or risk factors for developing arthritis in the hands.
Thank you, Dr. Baltzer. What about you, Tamara, for the feet?
Yes, thanks for having me join this talk. So I think what I wanted to first mention is, in order to better answer that question, I think we need to talk a little bit more about the different types of arthritis. I'm just trying to go back to the other slide. So, there's different types of arthritis that there's inflammatory arthritis, which is the most common cause I think that people know is a rheumatoid arthritis. And inflammatory arthritis is what we call an autoimmune disease or a systemic disease, which means that your body attacks its own joints, which can lead to the destruction of the lining of the joint over time. And 90% of people that have rheumatoid arthritis will have symptoms in their feet. And the joints that are affected usually first are the toe joints. And this can lead to pain in the bottom of the feet. And as the disease progresses, it can lead to deformities in the toes, most common like a hammer toe or a claw toe deformity and a bunion, which can be quite painful. And then as the disease progresses, the arthritis tends to move up the foot, more into the middle of the foot and into the back of the foot, known as the hind foot, and into the ankle. The other type of arthritis that's common in the feet and ankles is osteoarthritis, which is, the wear and tear of arthritis. So it's the wearing down of the lining over time, and this can be caused for many reasons, but genetics does play a strong component, just like in the hand. If you have a strong family history of osteoarthritis, then you're more susceptible to getting it in in the feet and the ankles, and also the types of activities that you've done throughout your life. If you have a very heavy manual labor type job, that's going to cause a lot more strain on the feet and ankles, especially because they're weight bearing bones, which can lead to wear and tear of that cartilage over time. Especially if you play a lot of sports, depending on if you've played a lot of high activity or high impact sports over your life, that can lead you to get arthritis in these areas as well. A third type of arthritis that is very common in the feet is also post-traumatic arthritis, which Dr. Baltzer already mentioned. So if you've had any previous traumas to your ankles or your feet, such as broken bones or multiple ankle sprains, so you're more susceptible to getting post-traumatic arthritis. And this mostly affects the ankle joint and the top of your foot.
Thank you, Tamara. Let's start with you again here. We've received many questions here, Tamara, about self-management strategies. So could you share some insights from your perspective related to the hands and feet?
Sure. And I think you already touched upon this earlier that, when you're dealing with arthritis in your feet and your ankles, sometimes it can be really challenging to manage the pain associated with it because you use your feet all the time. You're standing and walking for most of the day. So sometimes it can be quite challenging to try to find ways to manage this pain. But two of the simplest things that we can do to manage the pain associated with the arthritis in your feet and hands is footwear modification and activity modification. So with footwear modification, you can buy a special type of shoe that has something called a rocker bottom sole. And this is especially effective for people that have arthritis either in their ankle, especially if they have a really stiff ankle. So the rocker bottom shoe allows you to walk with a more normal stride. So it allows you still to do that heel and toe strike. And the shoe it compensates for the lack of motion that you have in your ankle. But it's also really good for people that have arthritis in the middle of their foot and in the big toe, because then these joints don't have to move as much when you're walking, which can help with pain management. Similarly, you can buy a shoe that has a very rigid sole, and this is especially effective for people that have arthritis in the middle of their foot and in the big toe. Again, with the rigid sole, these joints aren't moving as much when you're walking, which can help with pain management if you're on your feet for a long time. Patients that suffer from those toe deformities that I was mentioning earlier, like the hammer toes or the claw toes, you want something that has a very wide and deep toe box to accommodate these deformities, and so that there's not a lot of added pressure in these areas. Sometimes with arthritis in the feet, you can develop bone spurs, which you can visibly see on top of your foot, and on your big toe, there'd be these bony bumps. So you want to wear a shoe that has something that's very soft and stretchy on top to accommodate these bumps so that there's not added pressure. And similarly, if you're wearing a lace-up type shoe, you always want to make sure that the laces are very loose, again, to avoid any excessive pressure on these areas. Some other things that you can add into your footwear are things like toe spacers, which again can help with pain associated with the bunions and the claw toes, which can help to separate the toes when your foot is in the shoe, which can help to manage the pain in the lesser toes. Another insert that you can use, especially effective for big toe arthritis, is an orthotic that has a rigid plate underneath the big toe called a Morton's extension, which again, allows for the toe to remain quite stiff when you're walking, so it doesn't bend as much, so it's not as painful when you're walking. If you have arthritis in the ankle or the back of your foot, there's various types of ankle braces that you can wear in addition to your shoe, which can stabilize these joints and decrease the pain when you're walking and standing. The second major thing that we recommend to control pain in the long run is activity modification. So we usually recommend switching your high impact activities to low impact activities. So instead of running, we recommend cycling or the elliptical or swimming, because these activities allow you to remain active, allow you to to keep mobility in the joint, but decrease the stress that goes through these joints so you can manage the pain long term. Another good recommendation is pace your activity. So if you know that your pain comes on after a 30-minute walk, instead of going for one 30-minute walk, why don't you try to break up your activity and do 3 10-minute walks instead, so that your pain doesn't come on and you can still get that same amount of activity, but the pain is controlled throughout the day. Other management strategies are sometimes you can use assistive devices such as canes or walkers to help when you're walking for a long period of time. There's certain topical anti-inflammatory creams that can be very effective for pain relief in the feet, such as Voltaren gel or arnica gel. These are effective for the feet because these joints are very superficial. They're close to the skin surface. There's not a lot of fat or muscle tissue, so that these creams can penetrate into the joint and they can be quite effective. Lastly, physiotherapy is obviously very effective for early on in the disease, as it can help to maintain mobility and strength of the joints. And physiotherapy is also good if you have a flare of pain. So sometimes when you have a flare of pain, it can lead to some swelling around the joint. So there's certain modalities like ultrasound or TENS machine that can be applied to the joint to help with that inflammation.
Okay, thank you, Tamara. Dr. Baltzer, did you have anything to add to that around self-management strategies?
Yeah, thank you. So I think something that can be really helpful is just taking Tylenol if the pain is your major symptom, and then strengthening exercises to help support the base of the thumb. Not so much for the finger joints, but for the base of the thumb joint, where most commonly people are presenting with a lot of pain. Having the muscles that are around that strengthened, and there are different descriptions of how that can be done, that can be very helpful because it provides support to that joint. And then just making changes, ergonomic changes around your house. So there are different assistive devices you can help with just sort of daily activities to help modify how you're using your hands and putting the strain through your hands. So it's a larger grip instead of a smaller grip. It gives you a little bit more of mechanical advantage when you're trying to open jars and those sorts of things. So just having those types of devices can be very helpful in self-management. And then splinting can be a very helpful thing as well. Not so much for the finger joints, but for the base of the thumb joint. Having a splint that gives you a little bit of extra support. It's sort of like having the strengthening exercises and then adding that on when you're doing heavier things with your hands. And then topical anti-inflammatories, as Tamara mentioned, can be very helpful. Voltaren cream over the counter, those sorts of things can be very helpful to manage pain.
Okay, thank you for those answers. So prevention is such an important topic. Dr. Baltzer, I'll start with you this time. Is there anything that can be done to prevent arthritis in the hands and the feet?
So I think when it comes to the different types of arthritis that we've talked about, just trying not to injure your hands so that you don't have an injury that turns into an arthritic joint down the line is one way. And then when it comes to osteoarthritis, if you're starting to have painful joints, you may be heading down that path of progression of arthritis. And so there's no really great option that we're aware of. And that's why many people are doing research to understand how we can, halt the progression of osteoarthritis. And so this is where you can do activity modifications. So you're putting less strain through your joints. You can strengthen the muscles around the base of your thumb to support that joint better. You can wear splints. Those are things that can happen to hopefully take less strain and wear and tear on the joint so that things don't progress as quickly. But there's no one good way to prevent osteoarthritis from progressing. When it comes to other kinds of arthritis, the inflammatory type arthritis, like rheumatoid arthritis, there are disease-modifying agents that can be prescribed by rheumatologists and administered to help slow the disease or halt the disease and the progression of that. That's one way of preventing the further progression in inflammatory arthritis.
Okay, Tamara, do you have anything to add there about prevention?
I think Dr. Baltzer pretty much covered it, but I mean, yeah, same goes with the arthritis in the feet and ankles. If it's inflammatory arthritis, the best thing to prevent it is the medications, because their sole purpose is to prevent further destruction of the joint. So obviously you would need to speak with your rheumatologist in terms of what medications would be best to initiate, and you need to initiate those early. With osteoarthritis, again, there's nothing really specific to prevent it from progressing, but yeah, if you implement those activity modifications or the self-management strategies that I discussed previously early on at the initial onset of your symptoms, then that can kind of potentially slow down the progression of the disease. And I think one of the big things is, again, switching the activities that you do from the high impact to the low impact, because the low impact activities aren't going to put as much strain to the joint and could potentially slow down the wear of the cartilage over time.
Okay, so Tamara, I'm going to stay with you for the next question here. And, there comes a point where self-management strategies and some medications just aren't effective anymore. So if someone's in that situation, what other interventions could they consider?
Yeah, so I think, there's always surgical options, but surgery should kind of be the last resort kind of treatment. So, if you feel like you've tried everything what we call as non-operative care, and you feel like your pain is significant enough that it's affecting your ability to do your day-to-day activities and it's affecting your quality of life, then that's when you should speak to an orthopedic surgeon to discuss surgical options. I'm obviously not an orthopedic surgeon, but I do work very closely with a foot and ankle orthopedic surgeon, so I can speak to some of the surgical options that are available for people that suffer from pain associated with arthritis in the feet and ankles. So starting with the feet, the joints in the feet are very small and they're very close together. So you can't replace these joints. So if there is arthritis in the feet, the surgical option would be to fuse the joints that are arthritic. And fusion involves essentially gluing the joints together with some sort of surgical hardware, like a couple of small screws or a plate to stop the motion of that joint, which helps with pain. It will lead to a stiffer joint, but it is an excellent surgery for pain relief. But the word fusion often scares people because they think, well, if I'm losing the motion, how am I going to walk? So the answer to that is it depends on which joint is fused. So even if you fuse a few joints in your foot, it doesn't mean that you're going to lose the entire mobility of your foot. You'll still have bend in the ankle. You'll still be able to move the toes. So people do really well after fusion surgeries, even if you're fusing a big joint like the ankle joint. Oftentimes people can get back to walking without a limp, and they can get back to doing all of their extracurricular activities. So it is a very good surgery. And then I wanted to speak a little bit more about the ankle joint specifically, because I know a lot of people have questions like, do I do an ankle fusion or do I do an ankle replacement? And obviously the final decision is something that you make between yourself and the orthopedic surgeon. And this decision is kind of multifactorial. You have to look at lots of different factors before deciding which surgery is the best. You have to look at how old you are. You have to look at the severity of the arthritis, how active you are. Because with an ankle fusion, we tend to do that in patients that are younger and a little bit more active, because the ankle fusion lasts forever. Whereas an ankle replacement, it really only lasts about 10 to 15 years. So we typically reserve an ankle replacement for patients that are older, so that they can get the most life expectancy out of that joint. And with an ankle replacement, so if you're comparing it to, let's say, a hip or knee replacement, with hip and knee replacements, oftentimes you can get back your full range of motion. So, you can bend your knee fully, you can straighten your knee fully. So you'll get back more motion than when you had prior to the surgery. But with an ankle replacement, that's typically not the case. So with the ankle replacement, you will maintain the mobility that you have going into the surgery, but the main purpose of the surgery is for pain relief. So both the fusion and the replacement are excellent options for pain relief.
What about you, Dr. Baltzer, from your clinical experience here? What would you suggest for people that have tried several things?
Yeah, so when patients present to me and they have arthritis in the small joints of their fingers or on the base of their thumb, and they've tried a lot of options at home and nothing seems to be working, then I usually start with a corticosteroid injection into the joint. And that can be really helpful for pain relief. And it's something that, depending on how severe the arthritis is, I will do, a few times going forward in the future. So after 6 months, if the steroid injection wears off, I'm happy to administer another steroid injection if that brings relief. And that is something that can hold off on a surgery, which can be really, obviously people don't want to have an operation on their hands if they don't need to. I do offer other treatments. So I'll offer platelet-rich plasma, PRP, which some of you may have heard of for the base of the thumb, because that's a larger joint and getting into that joint, and that can give pain relief. It's something that come into the clinic, you have your blood drawn, and then it's spun down in a special centrifuge, and then we get a small amount of something called platelet-rich plasma, which can be a good anti-inflammatory, and that can bring a lot of pain relief for patients too for an extended period of time. Typically, that takes a little bit longer to work. So the steroid injection usually is pretty quick within a couple of weeks, whereas a PRP injection can take about 3 months for it to start to work. So that's another option. And then hyaluronic acid is another option. And so that's something that's naturally in cartilage. And so giving a hyaluronic acid injection into the joint as well can bring pain relief and help patients. Unfortunately, the PRP injections and the hyaluronic acid injections are a little bit less predictable. When they do bring pain relief, I find that it lasts for over a year. It takes a little bit longer to start working, but it lasts for a much longer period of time. Whereas the corticosteroid injections, generally, they last up to about 6 months, and then people want to come back and have another injection. So those are sort of my first line of defense. When someone comes in and they just aren't able to manage with the pain, they're not using their hands the way they want to be able to. And so then if we get to a point where they're having pain in a joint that is, waking them up at night, not allowing them to do their daily activities, that's when we start to get into the conversation around surgery. So for the small joints, I'm just going to show, so these joints right here, your distal interphalangeal joints, when you have painful arthritis in that joint and a little steroid injection doesn't help take that pain away, a little splint doesn't help, then that's when we start to think about doing a fusion. Just like Tamara said, that's making the two bones stick together so they become one bone. And you lose the motion in that joint. But it's a very effective operation for getting rid of pain. And if you lose the motion in that joint, typically if you have really painful arthritis, you don't have a lot of motion anyway, so it's not that much of a trade-off. But you do have to go through a potential surgery for that. In the next joint down, the PIP joint, the proximal interphalangeal joint, it all depends on how much motion is there. So the operation is to get rid of the pain, just like Tamara talked about. And so there are two options. You can either have a fusion or you could have a joint replacement. And the fusion is, again, putting those two bones together so that they don't move, which can be limiting for a finger because that's a pretty important motion to have. But if you don't have a lot of motion there anyway, that's when we think a fusion is a good option. If you do have a lot of motion preserved, but it's very painful, that's when we would think about doing a joint replacement. And so that can be an option for that joint. Again, these joint replacements have that limitation that they only are functional for a certain period of time, usually around 10 to 15 years for small joints. And so that's an important consideration and something we factor in depending on the age of the patient. Similarly, we have the same concept in these joints, the MCP joints, the metacarpal phalangeal joints. Often fusion is a very last resort for that because this motion is so critical to making a fist. So we often try to replace these joints rather than doing a fusion. Usually people don't have, they usually have pretty good range of motion in the joints. It's just very, very painful. The last joint that I'll talk about is this joint, the base of the thumb CMC joint. This is an area that's of special interest to me. I have a research program on this. I see a lot of patients that have this type of arthritis. And so I offer various treatments for this. One that's a little bit out there is I actually do something called back grafting. This was first described in Germany, and there are a few larger trials where they've actually shown that these patients have really good outcomes from this. So taking a little bit of fat from the tummy and injecting that into the joint can bring a significant amount of pain relief for patients that last for over a year. Kind of like the PRP and the hyaluronic acid injection, where it's a more minimally invasive approach to addressing the pain that someone's experiencing in the joint. And it doesn't work for everyone. So that's some of the research that I'm doing right now, is to try and understand why it works for some people and doesn't work for other people. And everyone's happy to have that operation if it's appropriate for them, because then everyone wants to get rid of fat from their tummy. So that's usually their response. And then if none of that will work and it's not the right thing, for the base of the thumb, there are operations where the sort of classic operations where we take out the trapezium. So there are two bones here, your metacarpal and your trapezium. And that's where the pain comes from at the base of the thumb. We actually take out the trapezium, which is a pretty intensive operation for the patient and quite painful for a few weeks afterwards, and leads to a sort of long recovery. So patients are generally recovering from that for about 3 to 6 months with intensive hand therapy, because you have to let things sort of settle in and make sure that the base of the thumb and the thumb itself is stable and things scar in. And then you go through a process of recovery, which is strengthening. So it's a bit of a longer recovery, and a lot of patients want to avoid that, particularly if you have patients that are coming in with painful arthritis that are in their 50s, 60s. They don't want to necessarily have this big operation and have the impact on your hand, which it creates, which is a lot of weakening of the hand and your grip strength. So I try to avoid that for as long as possible, but that's sort of the last resort for that joint. There are other options that are more widely available in the US and not as readily available in Canada, which involves a joint replacement, essentially putting in an implant in the base of the thumb here to get rid of that painful arthritis. So that's my algorithm for approaching painful arthritis when people are at a point where just managing it at home really isn't working.
Thank you both so much for sharing all of your experience and expertise with us tonight. Before we get into the Q&A, we've received a number of questions. Maybe I'll just ask for any final thoughts or recommendations. Dr. Baltzer, from you first.
I think we've both given a lot of information tonight. And I think one of the most important things is that if you're starting to have pain in the joints of your fingers, it's really good to see your family doctor, get an x-ray, identify if you do have early onset arthritis, and try to use some of these mitigation strategies that we've talked about. And if your pain isn't being managed, then ask for a referral to an orthopedic surgeon or a plastic surgeon or a hand surgeon, a foot and ankle surgeon, who can help to give you proper guidance on how to move forward so that you can live your life in as much of a pain-free state as possible, because you use your hands and your feet all the time. So it's pretty important to get a strategy for pain management early on.
What about you, Tamara?
Yeah, I think I would emphasize basically the same point. I think it's important to, take an active role in managing your own arthritis and do so early. So as soon as you get your first few symptoms associated with your arthritis and you have a confirmed diagnosis of arthritis, you should seek treatment and advice early on and as early as possible, because as soon as you start to implement some of these strategies that we talked about, like the activity modification, the footwear modification, this can help to control your pain long term, and it could potentially help to reduce any future damage in the joint and hopefully avoid any future surgery. So I think it's just really important to implement those strategies early for long-term success.
Excellent. So like I said, we have received a number of questions. I will just get started. I feel like both of you have complemented each other so well this evening, so you could probably both answer any of these questions, but I will direct you and feel free to chime in as you like. So both of you mentioned various fusion surgeries when applicable, and the question relates to what are the most important things that you should be doing post-surgery to ensure success, or do your best to ensure success? And when can people sort of start to feel, quote, normal after they've had that kind of surgery? I don't know. Dr. Baltzer, do you want to give a start here?
Sure, yeah. So I'll just speak to the hands because that's where I have experience. But generally, we like to wait a couple of months to ensure that the bone has healed well, following patients closely. We get x-rays post-operatively to make sure that there's no problems with the bone healing. And when we think that the bone is clinically healed, meaning we push on the area where the surgery was done and there's no pain, and the x-ray looks like things have healed, and that's when we start to feel comfortable with progressing with therapy around that specific joint. So we wouldn't be trying to move that joint, but we'd be moving the joints around it and starting to let a patient progress with things like strengthening activities. And generally that takes a couple of months before we're comfortable getting to that stage because we want to make sure that the bone has healed well. If the bone hasn't healed and you start to put weight on it, bear weight, move in that area, then you can loosen the hardware and you can lead to something called a non-union, which is what we definitely want to avoid because it means that the bone hasn't healed and the hardware is loose, or the screw or the plate, whatever it is that we've used to fix that fracture, fix the bone. And that means that the person would need to have an additional surgery or be immobilized for a prolonged period of time. So those are the things that we want to avoid happening. So as a patient, what you can do is just be very adherent to the guidance that's given to you by your surgeon and by the treating therapists that are involved in your care. One other thing is if you smoke and you've been told to stop smoking, you did stop smoking and you had your fusion surgery, don't start smoking again afterwards because that can be something that can also hinder your ability to heal the bone.
Okay. And Tamara, what about your experience working through therapies and with your surgical colleagues?
So I think with fusion surgeries in the feet and ankle, the recovery is a little bit longer than with the surgeries in the hand. So you have to be off of your foot for 3 months while everything heals. And then after that point, as long as everything on x-ray looks like it's solid, then that's when you can slowly start weight bearing. And usually for that 3 months, you're in a hard cast, and then you'll get transitioned into what we call a fracture boot, where you can take it on and off, but you still need to wear the boot when you start walking. And at that point is when you would initiate some physiotherapy. And again, as Dr. Baltzer mentioned, you're not doing physiotherapy for that specific joint because you don't have mobility in that joint, but it's more for to what we call gait training. So helping you wean out of the fracture boot and getting you to walk with a more normal stride and strengthening the muscles around the ankle and the feet. So typically full recovery can be up to 9 months. And at that point, you can start to get back to some of your extracurricular activities. But, everyone recovers differently. So, we say it can take up to a year for full recovery. And another thing that can be prolonged is swelling because the ankle and the feet are the lowest part of your body. So it's very common for swelling to last upwards of a year. So that's something that you need to keep in mind.
Okay. I think both of you also mentioned topical creams and Voltaren, and there's a question here about, there's a warning on the packaging about extended use of these topical creams. So maybe I'll ask you first, Tamara, is that something that people should be concerned about? This person mentions a 7-day time period.
I think, with it's still an anti-inflammatory. So I think one of the main concerns is, if you have really high blood pressure, because anti-inflammatories can affect blood pressure. And I think that even with a topical cream, it can affect this. So I think that's something you need to probably follow up with your family physician if you are going to be using it for an extended period of time.
Okay. We have a few questions here about are various things good or bad for you when you're experiencing arthritis in the hands and feet. So first, several people have actually asked about knitting. I don't know who wants to necessarily take this one, but is knitting good for arthritis in the hands? Dr. Baltzer, maybe I'll start with you.
Yeah, I don't know if people knit with their feet, but Tamara can tell us.
That'd be very impressive.
I think that knitting is something that's really great for maintaining mobility of the small joints in the hand. And I don't think that it causes arthritis. It may be something that contributes to pain that you're experiencing. And if it's something that you really like doing and it's interfering with your ability to do that activity, then that's a reason to go and see your healthcare provider to look into options for how you can reduce the pain so you can do that activity that you enjoy. But does knitting cause arthritis? No, I don't think so. It's not a very strenuous activity on your hands and joints.
And somebody's actually asked, is it actually good for arthritis pain to keep your small joints moving?
Yeah, I think that movement is good. If you stop moving when you have an arthritic joint, that's when it gets really stiff.
What about compression gloves and finger splints? And maybe we'll stay with the hands for a second. Dr. Baltzer, do you have a sense of whether you'd recommend those for people to consider?
I don't know that compression gloves would necessarily help with arthritis. They would for sure help with the swelling that may be associated. If you had swelling in the whole hand, I guess the compression glove may be of benefit, but a simple way is just to get something called Pro-Band tape. If you have like a finger that has some swelling in it or a joint that has some swelling in it, and put that on at nighttime, it's almost like a tensor bandage for your finger. And that can help to bring the swelling down. And it's a very simple thing. And then you don't have to have a whole glove on your hand. Splints can be helpful if you need something to protect a joint or to try and help with stretching out the joint. And usually at nighttime, I would recommend that because you're not really moving your hands that much. But during the day, if you keep a joint splinted like all of the time, then that can lead to stiffness. Sometimes we recommend it for the base of the thumb. If people are having a lot of pain and symptoms there, then splinting can be helpful there just to give that joint support. But that's more when you're doing heavier activities. But I wouldn't recommend wearing a splint all the time on your hand because that's when you start to get into trouble with stiffness.
And what about wearing braces in particular for your wrists at night? Is that something that you would recommend for people?
We recommend that to people all the time, primarily for carpal tunnel syndrome. People wear splints at night for carpal tunnel syndrome because we kind of tend to sleep with our wrists bent, and then that squishes the nerve, the median nerve that leads to carpal tunnel syndrome. So wearing a splint keeps your wrist in a neutral position and stops that compression of the nerve. If someone had arthritis in the wrist and they felt like that helped their symptoms to wear it at night, then I would recommend that for sure.
Okay, Tamara, a few questions here about people's foot arthritis. How can you tell if a symptom is related to arthritis or something else? I know this is tricky, but things like numbing, burning, that kind of thing. How can people help to sort that out?
Yeah, so with osteoarthritis, typically the symptom, it bothers you when you're using the foot. So the symptoms are what we call kind of mechanical pain. So you're putting weight through it, you're using your foot, you're using your ankle, it bothers you. When you come off of it and you rest it, the pain tends to go away. Sometimes you can get an achy, throbby pain after activity, but typically the pain is much worse when you're walking. With arthritis pain, there's not usually numbness or tingling or burning associated with that. Those symptoms tend to be more nerve related. And in the feet, you can develop what's called neuropathy, especially if someone's diabetic. You can get peripheral neuropathies, which could be leading to some of those symptoms that people experience. But from an arthritis type of pain, that's not typically a symptom that you would experience with arthritis.
And along the same lines, a couple questions here about distinguishing arthritis from plantar fasciitis.
So plantar fasciitis, the main symptom for plantar fasciitis is heel pain. So pain on the bottom of your heel, and it's typically much worse first thing in the morning. So when you take your first initial steps, it can be quite painful. And then as you start walking, then it tends to ease off. So if those are the symptoms that you're getting, it's probably plantar fasciitis. But with arthritis pain, it kind of comes on after you've been on your feet for a long time. You can have stiffness in the morning, but the pain comes on once you start using a little bit more. But with plantar fasciitis, it's very common to have localized pain in the bottom of your heel, which can sometimes spread into the arch of your foot, but the most concentrated pain is in the bottom of your heel.
Okay. A question here about best exercises for your largest digits, whether it be your big toe or your big thumb. So maybe Tamara, I'll stay with you for a second about toe exercises, and Dr. Baltzer, I don't know if you have some perspectives about people and their thumbs.
Yeah, so I mean, exercises for the feet, your feet, there's a lot of small muscles in your feet that are called your intrinsic muscles. So one of the simplest things to do to maintain the strength and mobility that you can do at home is, try picking things up with your feet. So like a marble off the floor, or if you put a towel underneath your foot and try to pick up the towel with your toes, that's going to activate all of those small muscles. With the big toe specifically, if you have arthritis in the big toe, you actually want to avoid exercises that are going to put that toe into an excessive bend position. So things like planks or lunges, or just, doing calf raises where you have to come up onto your tiptoes, that's actually going to aggravate the pain in the big toe. So I would avoid those exercises. So it's much better to do those towel curls or those scrunches to keep the toe mobile and strong.
Dr. Baltzer, from the perspective of exercises for your thumb, are there any that you could recommend for people?
So I will start off by saying I'm not a physiotherapist, but I do know of some exercises. So you can get just a gentle elastic band and put it around your fingers and do this kind of activity. And that's mainly to target these muscles right here, the thenar muscles in your thumb and support your thumb. So taking elastic. Similarly, just having a soft ball that you can grip, that can also help. Those would kind of be the main activities that I would know of, but I'm sure that there are specific exercises outlined, and I would imagine that the Arthritis Society would be a really great resource for those exercises.
Certainly, and I know that our moderator will direct people to those resources momentarily. We have a few people here who have experienced trigger fingers, and there's questions here about, are there specific considerations that they need to have if they've had that before and their arthritis, anything that they could be doing that could hurt one or the other. So Dr. Baltzer, I don't know if you can comment on that, people who have currently or have had trigger fingers.
Yeah, so is the question specific to management or how it relates to arthritis?
Well, both. I think there's some questions about if they treat one, is it going to exacerbate the other, or is it likely to come back if their arthritis gets worse? Those kinds of questions.
Yeah, so the treatment for trigger finger is sometimes just as simple as splinting at nighttime. Often people find that trigger finger is worse in the morning when they wake up. Their hands have been clasped all night, and then they feel like the finger gets stuck and it pops open, and then over the course of the day it gets better. But if that's not the case and it's something that's problematic throughout the day, then often using either a topical anti-inflammatory like the Baltzer for a short period of time, or a corticosteroid injection into the tendon area, not into the tendon itself, but around the tendon, can be helpful. Trigger finger is essentially, just to differentiate it from arthritis, is when the tendons that bend your fingers down, they run through a tight tunnel system for each finger. And right around here is the tightest point. And so it just means that the tendons are getting stuck when you're pulling them down, and then they pop back out when you bring the finger out straight. So that's what trigger finger is. It's inflammation of the tendon sheath or of the tendon itself. So the steroid injection can be really helpful to bring that inflammation down. Does that cause your arthritis to get worse? No, that wouldn't cause your arthritis to get worse. Sometimes if you have surgery for arthritis. So let's say you had a surgery for your finger and you had fusion done, then that inflammation that's created by the surgeries can sometimes lead to a secondary trigger finger. So it's not uncommon for people to have an operation in their hand. And then, a month later, they come in and they're like, doc, my finger's now doing this clicking thing. And so then that's when we would, educate them about trigger finger, explain that that's probably related to inflammation of surgery. Maybe they even had a little bit of mild trigger finger before and they didn't recognize it and it just sort of tipped them over the edge. So that's the only way I could think that an arthritis treatment could exacerbate someone to have trigger finger, but it wouldn't really work the other way around.
Okay. Tamara, we have some questions here about what just causes that inflammation or the burning sensation in the feet for people with arthritis. Could you explain that a little bit of a symptom that people experience?
So like I mentioned before, the burning is not typical. I don't think the arthritis is causing the burning pain. So it's probably some other underlying condition, likely nerve related. Oftentimes if that's their main symptom, what we would do is we would recommend further testing, specific nerve testing like EMG or nerve conduction studies, just to see if there is any damage to some of the nerves in your feet. Another area where the pain could be coming from is from the back. So if people have really bad arthritis in their back, sometimes it can narrow down the passage where the spinal cord and the nerves go through, or if they have a disc that's compressing on the nerves, it can lead to some numbness in the feet as well. So those are kind of the two areas that we would need to look into further to see what's causing the numbness in their feet, but it's not typically related to the arthritis.
Okay, a few questions here about massage guns, and if you would recommend those for people with arthritis. If there's any evidence to support their use, I guess.
I mean, I think, I think that, I don't think there's any harm in using them. I mean, if you feel like it's helping with your symptoms, I think you continue using them. Is it going to change the arthritis? No, but I think the massage guns are more for the soft tissue and the muscles around the joint. So if those muscles are feeling tight, then the massage guns I think can help with that, but it's not really going to have any effect on the arthritis itself.
Okay, Dr. Baltzer, you mentioned corticosteroid injections, and there are questions here about you only have so many, and does it come to a point where they're no longer effective?
Yeah, so with corticosteroid injections, it's something that if someone has really advanced arthritis and there's no cartilage left, and it's something that gives symptomatic relief, I will give steroid injections as long as it works for that patient. If it's a patient who has a joint that is symptomatic, but they're younger and they still have cartilage present, then I will look for other solutions to try and treat that rather than give a corticosteroid injection, because there is some evidence to suggest that a corticosteroid injection can actually be harmful for cartilage. So if there's cartilage left, then I will try and avoid that. And then the question about whether corticosteroid injections stop working, absolutely. After a period of time, some people just find that they don't resolve the pain. Sometimes even after one injection, it doesn't help. And that's when we start having conversations about alternative treatments or surgeries that may be able to address the pain depending on the amount of pain that the patient is experiencing.
And Dr. Baltzer, is there a relationship between Reynolds disease and the development of osteoarthritis in the hands?
No, I don't think that there is an association that I'm aware of between Reynolds, which is a vascular phenomenon, and osteoarthritis. Reynolds is when the small vessels in your hand go into vasospasm when you're exposed to cold, and your fingers go through this sort of cycle of being white and then blue and then red, and it can be quite painful. It can be associated with scleroderma or other inflammatory conditions that are more like a vascular sort of position or presentation, and they can be associated with arthritis. So that's more along the lines of inflammatory arthritis. So yes, you can have a reynolds phenomenon that's associated with inflammatory arthritis, but not with osteoarthritis. I wouldn't say that those two things are associated.
Okay. And what are your thoughts around finger splints specifically, or ring finger splints, Dr. Baltzer?
For what kind of condition?
For arthritis of the hands is as specific as we have here.
Okay, so sorry, which kind of splints again? Tell me.
Ring finger splints?
Ring finger splints?
Mm-hmm.
I don't know exactly. Oh, maybe they're talking about like a figure of 8 kind of ring splint. Okay. I'm not sure exactly what this person's talking about, but that's a splint that looks almost like it looks like a figure of 8, and it slips over the digit and it looks like a ring. And that can help hold the joint in a specific posture if we're trying to fight an abnormal posturing of the joint. So sometimes people will have something called a swan neck deformity, where the joint is hyperextended at the PIP joint and then flexed at the DIP joint. So the ring finger splint can help hold you in a bit of flexion to overcome that tendency of your tendon imbalance that's causing you to have the swan neck deformity. That's more in swan neck deformity is something that happens more in like a rheumatoid arthritis type picture, not so much in an osteoarthritis picture, but it can be very helpful in maintaining a more normal posture of the digit.
We have a few questions here about, and Tamara, I'll ask you first. How do you know when the exercises you are doing to try and treat your arthritis are actually too much, and when they might actually be doing some harm?
Yeah, so I think it's about how much pain is causing you. So, a little bit of pain is okay. But, if you're looking at, we use this numeric pain rating scale, which is on 0 to 10. So 0 is no pain and 10 is the worst pain. So if you feel it's causing 10 out of 10 pain, then definitely stop doing that exercise and scale it back. So I think, anywhere between 5 out of 10 and lower, I think is an acceptable amount of pain. So anything above that, then that exercise is probably aggravating the joint. It's not necessarily causing harm, but I think it's just aggravating things, so that you either want to try to modify that exercise that you're doing so that it's not as painful, or just completely eliminate that and try something else.
Okay. And Dr. Baltzer, I know you work with a team of physiotherapists, and there's a few questions here about, are there any assistive devices that people could consider when they're wanting to do exercises like weightlifting or things that could be pretty tricky for people who have arthritis in the hands? Are there any particular assistive devices that people might consider?
Yeah, that's a good question. I think that trying to modify your exercises so that you're not loading through your hands and having to do large gripping activities is probably a good start. So if there's any way you can modify so that you're working on machines where you're loading the weight through either your forearms or through your upper arms, that would be helpful. So trying to make it so that you're not loading the weight through your hands. But I don't know that there are assistive devices, and there may be, and that I'm just not aware of, that can make weightlifting less strenuous on your joints. I think the problem is that the heavier the weight, the more you're going to have to grip. And so I don't know that there would be things that you can modify for that. But that's a good question for someone who focuses specifically on hand therapy and physiotherapy focused on the hands. Mm-hmm. Occupational therapy.
Tamara, I know that you talked about some various things that can help with respect to different foot splints or foot soles and other things. Is there anything that you recommend for people who are wanting to exercise for their arthritis and what they should be considering in terms of assistive devices?
Sorry, are you asking like things to put into their footwear?
Could be footwear. Are there particular, some people are asking, are there particular running shoes that they should be looking at? Anything that you would, your go-to in terms of recommending for people who are looking to get more physically active, but are also managing their arthritis?
Yeah, so I think if you're looking at the running shoe, I get the things that I had already mentioned before. So something that has a rigid sole that's really supportive. If you can take your current running shoe and kind of bend it in half, it's probably not the best. So you want something that doesn't have a lot of give, which again is really going to stabilize the joints in your midfoot and your big toe, especially if you have arthritis in those joints. And the less those joints move, the less pain you're going to have, which is going to allow you to be more active and do the exercises that you want to do. Like if you want to do some cardio exercises where you want to go on the treadmill, those types of supportive stiff shoes are going to allow you to be able to be on that treadmill, even 5 or 10 minutes longer before things can get painful. So I think that is one of the main things. And then if it does have a little bit of a rocker bottom, that's also helpful. In terms of specific brands, I know a lot of patients really like a brand of running shoe called Hoka. So it's Hoka. A lot of people have come to us and say, I've tried this, it's fantastic. And it helps with a variety of different conditions, not just arthritis in the feet, but people have had really good results with that. And I know Skechers also makes some rocker bottom shoes and material that's very stretchy on top and soft, which can accommodate some of those deformities that I was discussing earlier.
Thank you, Tamara. So I just want to take a moment to thank you both so much for sharing all of your thoughts with us today. I know that those were many questions that we went through from the audience that were pretty diverse. We would just like to take a few moments to get the audience's feedback on today's presentation. So for those of you watching on Zoom, you'll see a poll question come up on your screen with a few answers. So do click on the response that reflects your thoughts. Did you find the information in today's webinar helpful to you? We'll also be sending an evaluation form when we email the recordings, so please do fill that out as well if you have the opportunity. We really do use that feedback to shape future Arthritis Talks webinars, and we truly value your input. Once again, we are grateful to our partners, Pfizer, United Way Winnipeg, for their support of this event. As a member of the arthritis community, we know that you care about improving the lives of people with arthritis. Today, we invite you to join our monthly giving club and help bring programs like Arthritis Talks to thousands of Canadians. Visit arthritis.ca/give-monthly to join. We'll be back on February 16th with Arthritis Talks Medical Cannabis 101 with Dr. Shelley Turner. For more information on that session, please visit arthritis.ca/arthritis talks. This concludes Arthritis Talks, Arthritis in the Hands and Feet. On behalf of all of us at the Arthritis Society, thank you for joining us tonight.